بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعذروني هاي صار فترة ما بسوي برزنتيشن بالعربي، فنرحب بكل الحضور الموجودين. إن شاء الله يعني أحاول ألخص يعني بحث الدكتوراه مو 20 minutes، يعني أتصور راح توصل نص ساعة. إن شاء الله تكون يعني بشكل overall تستفادوا من البحث بشكل عام، وأحاول إنه أبرز أهم النقاط المهمة به. So my thesis is medicine management in care homes. So you can notice it is just, we can separate it into two key points: medicine management and care homes. I know we have no much care homes in Iraq, maybe some opening now, but it is not about the idea of care homes, it's more about the idea of the services, especially to older adult population. And for the medicine management, we will discuss later on what we mean by medicine management. So, simple definition for care homes: accommodation that provide personal care to individuals who need extra support and help in their daily activities. In UK, there are two types of care homes: residential and nursing home. They give the same personal care, but in nursing home, they give extra nursing care for special conditions, for multimorbid patients, and also the staff who administer the medication. In nursing home, they are a registered nurse, while in residential home, they are either a care assistant or social carer. A lot of studies highlighted a lot of issues around medicine management in care homes. So we try to explore what are those issues. Some related facts. In UK, a huge number of older adult population aged 65 and older, so 11 million, which is considered a large number. This number is expected to increase by 2000 over 40% in the next 17 years to 16 million. Most of the older adult populations in care homes in their 80 or 90. I have some of the residents in my study, their age is over 112. So their date of birth is 1901, 1902. Also, most of them, they have long-standing medical conditions, which mean multimorbid conditions. Also, a lot of numbers of nursing home and residential home in UK. Since we are talking about older adult populations, so some characteristics of this particular population: they have complex medical conditions, diabetes, hypertension, a lot of disease. Also, they have, since they have multiple disease conditions, they prescribed a lot of medications, so they suffer definitely from polypharmacy. Also, they have cognitive impairment, which means they don't have the ability to handle their medication by themselves, so they need help in taking their medications. Also, they receive their medications from multiple interventions, so either from the GP, from the hospital, from the the one who is responsible for physiotherapy. Okay, so a lot of interventions. And also they suffer from geriatric syndrome. Geriatric syndrome is, there is no broad definition for geriatric syndrome, but it is, we can consider like a series of clinical conditions, especially falls, frailty, dementia. Some information is related to the study also. Polypharmacy, I will explain in details what all the definitions about polypharmacy, but what I use in this thesis is the absolute number of medications. So the concurrent use of 5 medication or more, and extensive polypharmacy, the residents who receive 10 medication or more. Also, there is a very important study, a CHAM study, which is the key model in this, in estimating the medication management in care homes in UK. They estimated that older adult or residents in care homes, they received at least 7 to 8 average medication, which is a large number. Also, as an older adult population, they have age-related changes in pharmacokinetics and pharmacodynamic, which may increase the sensitivity to the response of the drug. A lot of regulations. I think this is the main difference from UK or even any European countries with Iraq. Here, we handle the medication, but there is no policy, there is no regulation for the medicine management. There is like the Regulation 13 Outcome 9, which is responsible for for assuring safe and effective management of medicines in care homes. And also there is institution, for example, the Care Inspectorate for Wales is responsible for the inspection of care homes, the medicine management in care homes, and their annual report, which was in 2019 to 2013, when I started my PhD, highlighted a lot of, like nearly 11 percentage medication administration issues for resident in care home. So, as I mentioned in the beginning, my title was Medicine Management. So medicine management is a complex multifactorial process. It includes 6 key components. Maybe it is obvious for most of you that the medicine management started from the prescribing, but in care homes it started from ordering, because it is not like an institution who prescribe. It is order the medication at the beginning of each month to the GP, and the GP or the prescriber who will prescribe the medication. Then we have the transcribing and verifying and dispensing. All of these processes set out at the point of community pharmacy, who order the medication, double check the medication, then they just send the medication to the care homes. When the care homes they receive the medication, they store the medication, then they will start administering the medication by the care home staff, either we mentioned registered nurse or social career. Then there will be like monitoring and reporting for any adverse drug events. And also there is a process, I didn't put it here, at the end of each medication cycle, any unused medication should be returned either to the community pharmacy in case of residential care home, or to the clinical supplier in case of nursing home. So the aim of my study was to explore medicine management in care homes, focusing on prescribing, administration, and waste of medicine through 4 main objectives. The first one, I will also, in each study, I will explain in detail, exploring the prescribing pattern in 10 care homes in South Wales. And also the second was to do retrospective analysis of medication administration record, MAR charts, something similar to the chart in hospitals, nearly similar, and to identify any medicine administration issues from the MAR charts, then a determination for the value of waste of medicine, and also because in objective 2 we try to identify medication administration errors, so we want to know if there are any clinical consequences and costs behind those medication administration errors. This is like an overview of the study. Then I think this is the main thing, the MAR charts, because my study mainly depend on the reviewing of MAR charts. So this is maybe similar to the chart somehow but I think some details. In that, because all the medication administration records or the MAR charts are anonymized, so nothing related to the name of the resident, name of the pharmacy, anything may break the privacy of the resident. So just the date of birth, and this was my ID for the study, to know, for example, the medication for each resident. And also you notice this is not a prescription, it is a copy of prescription. So in this part, the medication, all the information about the medication, the strength, the dose, the route of administration, frequency. Then there is, may notice the column, time, because in each care home there are 3 to 4 medication round, which means the staff administer medication in 4 rounds. So either they mention the round by mentioning the time, for example, 8, 12, for example, whatever, 6, then 10 p.m. So it is arranged during the day, or they mention, for example, breakfast, lunch, tea time, and evening. The boxes, you notice a lot of boxes. This is all the care homes, they use this MAR charts for 28 days. So this is medication cycle for 28 days. And this tiny boxes is the box where the staff who administer the medication should sign the box after the administration. And this is like a legal requirement. And at the bottom, I know it's very small, but at the bottom there is a defined code, which means, for example, there are some conditions where the staff want to administer the medication, either the resident sleep, having nausea or vomiting, or any condition, so there is a code. For example, nausea, vomiting, they put N. For asleep, A, for example, it depends. Those codes, different, no much differences between care homes, but it is very important if the resident didn't receive the medication, the staff should put the code. If it is left blank, this is considered omission. Even it is not observational study, it is a retrospective. So we assumed any blank boxes, the resident didn't receive the medication. So this is also considered an error. I will also explain that later on. So this is all the information that should be in the MAR charts. For the first part of my study, which is to explore the prescribing pattern in 10 care homes in South Wales region. So definitely in any study, I'm not sure if it's not in UK, in any country, there is ethical approval. The ethical approval, it depends on the study. For the retrospective analysis, just ethical approval from the School of Pharmacy at Cardiff University was enough. Then we recruited the care home. The recruitment was in accordance between Cardiff University and the company which take part in this study. And the recruitment was all care homes that fully registered with the Care Inspectorate for Wales and care for older adults population, either residential or nursing home. Then looking at the MAR charts for the overall, it was like there was 260 residents overall in 10 care homes. So all the medications for those 260 residents, I just extracted the medications, all the information about the medications, dose, strength, any information related to the medication, and also, but I just exclude the dressing, nutritional supplement, and any alliance, for example, because all these not considered as a medication, so just the medication. Then all the data input into Excel spreadsheet. For that reason, I wanted to know the prescribing pattern in care homes. Then I wanted to know or to identify the prevalence of polypharmacy. And the third part was to identify the prevalence of potentially inappropriate medication. Also, I explained the method used. I told you in the beginning, I used the absolute number of medication for the definition of polypharmacy. Nowadays, in a systematic review, there were more than 24 definitions for polypharmacy, and they classified or divided into quantitative and qualitative definition. I'm sure maybe in most of the studies here maybe in Iraq or in any other country, they depend or rely on the absolute number. The most common is the prescription of 5 medication or more, and this is for polypharmacy, 10 medication or more for excessive polypharmacy. Now, the idea was toward the use of qualitative, which means even if the resident or any individual or patient who take, for example, 5 medication or more, may be not considered as a polypharmacy because all those medications are appropriate. So we need to look at the inappropriate medication. This is the other definition of polypharmacy. So this is like just some of the definition. This table shows the potentially inappropriate medication that was extracted from my study. So we ended with 32 medications that should be avoided. Another 12 I couldn't put in the slide. There is not much space. You may ask what was the procedure or the method to identify the prevalence of potentially inappropriate medication. The definition of potentially inappropriate medication is the medication that their risk for adverse drug events outweigh their therapeutic benefit when there are other alternative or safer medication. A lot of screening tools or method used to identify the prevalence of PIMS, the shortcut. PIMS divided into implicit and explicit criteria. The implicit criteria, it is more accurate because it is more about the face-to-face discussion between the clinician and the patient. So each clinician have a conversation with the patient according to their medical background. They decide those medication for this particular patient appropriate or not. But even it's accurate, but it's time consuming because it's just one-to-one. The other type of criteria, the name for this criteria, explicit criteria. This is the most commonly used, 13 method within the explicit criteria. It lists the medication that should be avoided or used with caution, so it's more generalizable, and we can apply it. From those 13, the most commonly used method, stop-start criteria, which is UK-based, and Beers criteria, which is United States-based. In my case, I use Beers criteria. Even Beers criteria, I know it's US-based, but for my condition, because I couldn't get access to the medical records of residents, I just have the RMR charts. So Beers criteria, it classified medication into 3 groups. The medication that should be avoided, independent on disease or condition, the one that I use in my study. Group of medication that should avoided, but dependent or for certain disease or condition, and the group of medication that should be used with caution. So when I applied the Beers criteria, I ended with, as you see in this table, 32 drugs that should be avoided, independent on disease or condition, and another 2 that should be used with caution. This table, this is a result of first study. So this table shows the characteristic of resident care homes, so 10 care homes, 2 residential and 8 nursing home. The average age was 83. The range of medication was variable from 0 in care home. For example, one of the residents in care home 4 was received, for example, 0, no medication, to 25 medications in care home number 10. So there is a variability in the number of medication. When I extracted the medications in 10 care homes, I tried to classify them according to BNF therapeutic category, so according to the system. So I think it's obvious that the most medications prescribed within the nervous system, then followed by cardiovascular, then by gastrointestinal. This is for 10 care homes. I have another table, but I didn't put it here. I classified per care home. So those, the pie chart, the first one was for the 10 care homes, but I couldn't put to the table because no much space also to illustrate medication by category in each care home. But it gave the same idea. Nervous systems followed by cardiovascular, followed by gastrointestinal. Then in this pie chart, I tried to classify it as like sub-analysis or subcategory. So in each system, the medication used within each system, and it is obvious from the nervous system, non-opioid, especially paracetamol and paracetamol-containing product, the main one prescribed. Then, for example, for the cardiovascular, antiplatelets, especially aspirin. For the, for example, gastrointestinal, definitely the green one, the laxative, also mainly used or prescribed for resident in care homes. I told you also that I identified the prevalence of polypharmacy. So 84, which is a huge number, 84% of residents received polypharmacy, and 33, which means third of the residents from the 260 residents, nearly third were received excessive polypharmacy, which means 10 medication or more, which is a huge number also. For the second one, for the potentially inappropriate medication, also 87 residents were received potentially inappropriate, but it is for those at least one. And in most studies, they not just mention the, for example, the prevalence. Also, they classify them to those who, for example, prescribed 1, 2, 3 or more. So overall, 87. But then I just separate them into 3 groups. So also you may notice nearly 43, which is also a big number, of residents were prescribed at least 3 or more potential inappropriate medication. Then those potentially inappropriate medication, I try to classify them according to therapeutic category in the BNF. So like a summarization, most of those potentially inappropriate medication were proton pump inhibitors, then followed by psychotropic agent, which include antipsychotic, hypnotics, and anxiolytic. And this is considered one of the major concerns in care homes, because most of them, they received antipsychotic medication. I tried also to know, because also many studies, they wanted to know if there are any correlation between or any other parameters that may affect the prevalence of potentially inappropriate medication. It depends on the criteria or the parameters that you have in your study. So you may include a lot of parameters, but in my case, I have just 4 parameters: extensive of polypharmacy, average age, number of medications, and the number of residents. So it was obvious by running the Poisson correlation that there is a strong correlation between the prevalence of potentially inappropriate medication with polypharmacy and with the number of medication. Maybe I didn't mention that the third parameter that I measured in this study was the anticholinergic burden. This also considered one of the main concerns, because they noticed that residents who prescribed drugs with anticholinergic properties, there is a very strong correlation with the appearance of cognitive impairment. A lot of scales used to identify the anticholinergic burden, but the one that I use from the prescribing indicator parameters in Wales, which was the anticholinergic effect on cognition, the AEC score, which classified the drugs with anticholinergic properties into 4 score from 0, no medication, to score 3, which is the highest medication which may cause cognitive impairment. So also there was another table, but from the result, it was obvious that more than 50% of residents were received anticholinergic drugs with anticholinergic properties. Then this figure shows the cumulative scale or cumulative score, which means, for example, one of the residents may receive drug with score 1, or maybe with another medication with score 3. So the overall score will be for this resident is 4. So I use the cumulative because there is a study mentioned that any patient who received the score 3 to 5, there is possibility of clinical problem. But if the resident received more than score 5, I have until 9, there is like the risk of severe cognitive impairment. So nearly, I think, 14 residents were received score 5 to 9. So in conclusion, I think you notice that the polypharmacy and extensive polypharmacy was significant. The potentially inappropriate medications also, the prevalence was high, very high. All these may put the residents at risk of cognitive impairment, geriatric syndromes, and a lot of complex condition. So I think careful consideration should be applied to prescribing practice and also to decrease or reduce any medicine burden. This is the first study. The second study was to identify administration errors from 10 care homes. Also, I used the same principle, retrospective analysis of MAR charts. The same procedure, ethical approval, recruitments of care homes. But in this case, maybe you may read about medication administration errors. Most studies, they maybe focus on administration errors. Some of them on prescribing errors. Most of the studies also not mention the category. They just mention, for example, in this study there is a lot of extra dose, wrong time, so different error type. So in our study, we try to develop a protocol specific for this study. So we categorize error. And this was not an easy process because we don't have like a guideline. But we just try to depend on the guideline, which was a lot of guidelines in UK, especially NICE guidelines, which outline a series of best practice for safe and effective management of care homes. So we use those criteria from the guideline and then try to match between what we found in the MAR charts with the criteria. Maybe it's very small, but for example, for the criteria should be date of birth should be mentioned in the MAR charts. For example, those a lot of information should be mentioned in the MAR charts. So when I look at the MAR charts, I try to find any discrepancy between the guideline and the MAR chart. This process involves a series of conversation, discussion with the research team, because it is 10 care homes, and we try to, as I mentioned, to develop a rule book. When we develop this rule book, we use it for for test care home, then we use it for care home number 1, and each time we try to, if we find any different, like a new error, not identified previously, we return back to the same series until we reach consensus that this is the rule book that should be used to identify errors in care homes.
So the markers has only the date of birth for the patient?
This is the ID.
But does it also have the disease condition?
No. Just the medication. Just the medication. It's like,
based on the medication, the best guess is that this patient has hypertension.
Do you know, maybe this was one of the questions from the external examiner. I told him I can't get access to the medical records. It's not easy, especially for international student. But he said, you can, from the medication, you can give a good estimation for the disease. It's obvious from the medication if it's suffer from hypertension, from diabetes. It can give indication. But I don't have information about the medical record or the disease state.
Then talking about the prescription pattern, trying to, you have different population of patients, different disease conditions, and then you have different prescribers, different prescription habits.
Yeah.
I might have missed that, but I'll ask you later. Put it in a simple way.
Okay. So we end up, I think this is the first study to categorize error into 5 main categories. Administration report errors, Marchart errors, regulatory errors, stock errors, and the fifth one, that not be categorized, which mean miscellaneous. Anything cannot be categorized depending on the Marchart alone. I try to estimate also the error rate. The simple way to estimate the error rate, just divide by number of medication per resident, number of resident per week, for example, to give the error rate. But there is a most accurate way to identify the error rate, which use the total opportunities for error as a denominator, and the numerator will be the number of errors identified. So also there's another table which explains this, the use of this equation. This table shows the total number, or the absolute total number of errors overall in care homes. Care home number 8, the best, we can consider the best performing care home with the lowest number of error in general, and care home 10 with the highest number of medication. And I also just focus on the administration error because it is the most related error that may cause resident harm. So also, because in the first table I shows you the absolute number of medication, the absolute number of errors. But because there is a variability in the number of residents, for example, one of their care home with 19 residents, some of them with 53. So to overcome this discrepancy, I just calculate the error rate per resident per week. And also that give the same idea. The best performing care home 8 with the lowest performing is care home number 10. The second table shows I told you that I measure the error rate, depend on the total opportunities for error. Also, this was not an easy process because I have 720 Marcharts. I have to look for each administration. So the total opportunities for error, it is the number of administration scheduled to be administered to the resident plus any omitted doses. So I end up with 84,000 administration, and I counted from the boxes of the Marcharts. Also, we developed a protocol because to make it more easier, and this protocol I think took 1 month. Then I used another 1 month to calculate the number of administrations to just reach to the 8.6%. And this was incredibly similar to a charm study, which is the key model in this study with 8.4 administration error rate. Then I tried to classify it in 10 care homes, the 5 main categories. Even there is no clear pattern in the graph, but it may give an idea that most 7 care homes administration error was the most predominant type of error. Then for the because in each category, so I not just classified into 5 main categories. In each category, there is subcategory. So for example, there are some of the audience may ask, it is not related to patient, may not cause resident harm, but it may happen that, for example, in some case, the medication may run out and there will be delay in the treatment of the resident. So also it is considered important. Also, I try to know if there is any correlation between the total number of administration with type of error categories, and it is obvious administration error and mark chart error were strongly correlated with the total number of administration. Also identified, I identified the prevalence of potentially inappropriate medication. Also, I wanted to know if there are any errors, administration errors and risk error associated with potentially inappropriate medication. And also then break down the administration errors for the potentially inappropriate medication, and it's obvious like proton pump inhibitors, psychotropic agents were responsible for the highest number of errors, especially omission. Also, there are cases of extra dose for some hypnotics, extra dose for proton pump inhibitors, which should be considered. So in conclusion, I ended from the identification. I tried to explain, but to mention each subcategory will take a lot of time. So we end up with 16,000, more than 16,000 error type. And those were classified or categorized into 5 main categories. And as I told you, each category subclassified to subcategories. And also medicine administration error responsible for the highest percentage of error, omission especially, and clinical outcome for those medication errors should be taken into account. The third study was the exploration of the medicine waste in care homes. A lot of definitions for the waste of medicine. The one I used that any consumed, the resident will receive the medication, any unconsumed or partly consumed medicines that return, not used, and return to the pharmacy or return to the clinical supplier considered physically discarded, considered as a waste. And because in care homes they have a policy that at the end of each medication cycle there should be a return book, and this return book should mention all the medication, quantity of the medication that unused, also the strength, the name of the medication, the reason for disposal, for example, patient death or whatever the cause of disposal, and should be signed also. So this table shows the causes for waste of medicine. This is general, not in care home. For example, I think most of the reason for waste of medicine, for example, in our case as a family, stockpile. We just want to stock medication just in case, like from the future. It may happen, for example, in care homes because they repeat the dispensing, just ordering the same medication each month. So this also may lead to waste. Maybe and this, can be classified into avoidable and non-avoidable waste. The avoidable waste, which mean, for example, can be for repeat prescription, so we can avoid that. For example, exactly. One of the main reasons for, they noticed that for the waste of medicine, non-adherence. And I will show you also another graph or like to explain the combination between therapeutic loss and the waste of medicine. So non-adherence is considered one of the reasons, and this can be avoidable. Non-avoidable patient death, change in the condition of the patient, for example, either progresses, for example, recovery, or for example, change in the medication. This is unavoidable. We cannot avoid that. This, what I meant by the correlation or the relationship between the therapeutic loss and the waste of medicine. So it may happen, and this is explain the idea of intentional and non-intentional adherence. And this is the main idea that they are focusing on in UK now, because they notice that non-adherence is responsible for therapeutic loss for a lot of patients. So you may have like, you consume the medication, but there is no therapeutic response because this is the non-adherence. Or if you consumed with therapeutic, this means adherence. So the methodology the same, ethical approval, recruitment of care homes, another 7, though not the same 10 care homes for the first and second study. So for the 7 care homes, there was also no methodology specified to just estimate the value of waste. So we developed 2 methodology. The first one from the return book. So just enter all the medications with all the information into an Excel spreadsheet. And the second one, we did overstock. The overstock include 2 things. We depend on the marchers. So we visit the care home at the end, for example, before, for example, 4 days from the end of the medication cycle, and we, according to the marchers and the instructions that, for example, this medication should be prescribed twice daily. So we think for the remaining 3, the stock should be in the trolley 6. If it is above that, this may consider waste. And also we tried count every medication, dressing, nutritional supplement in the care home, in the cabinets, in the shelves, in any store position in the care home. So to try to overcome all the missing in the number of medication. We also, the process of counting involved number of doses. So we not just count the tablet. We also, for the cream, for the nebulizer, whatever, the liquid, but it was for like visual estimation. And then we use this equation, which is a simple equation, to know the cost of medication, the cost of waste medicine, from a price from the BNF. It may happen some of the medication without price, so we estimate the smallest bag. Some of them, for example, with no strength, we estimate the smallest strength. So this is the value of waste of medicine in 7 care homes, which 3,100 in 1 month, which is also considered a large number. Then I try to, the waste of the medication wasted, I try to categorize them by also BNF therapeutic category. And it is obvious that the medication wasted act on nervous system responsible for the highest value, 800, followed by cardiovascular and gastrointestinal. Then we wanted to know the value of waste, if it is related to the cost per pag, because they have, for example, the pag less than 10 pounds, and there is some of the medication is very expensive. So we noticed that more than 80% of the waste were related to the cost of pag, which was less than 10 pounds. Then I tried to also estimate the value of waste according to the higher quantity wasted. And I just put 3, but I just estimated for the top 5. And it is obvious from the, maybe it's not clear here, but paracetamol and laxative were responsible for the higher quantity wasted. And even I did it for the highest cost. For example, some of the medication, they have very high cost. So I tried also to take the top 5, but the same idea, paracetamol and laxatives, even with the lowest cost, they were responsible for the highest waste. Because the medication they classified into regular and irregular. Maybe, I don't know if we have required medication here, or PRN medication. The PRN medication cause a lot of problems in UK, because most of the medication they prescribe under the name of PRN or when required, especially for paracetamol, and it was responsible for the highest value of waste. But there is a variability in care homes. Some of the care homes, the regular was higher. One care home, both of them the same. One of them, like the when required, the cost was higher. So in conclusion, we noticed that a lot of medication wasted, and all those waste medications, or the money behind all this waste medication, can be used for other healthcare services. So audit to the cost of medicine is very important, to know if there is any medication wasted, and try to overcome all the causes behind the waste of medicine. So thank you for listening. If you have any question.
The
Dr. Fadi, thank you very much for your nice presentation. I would like to ask you why did not try the prospective study in addition to the retrospective study?
It was difficult. It was difficult, because they want to know the first year of the study. There was like a pre and post implementation, because there was a device, proactive device. They want to know if there are any differences in the number of errors estimated by using the paper-based mark charts and the device. So we depend entirely on the mark charts for as a retrospective study. So this was the way of the study. We didn't look for the prospective. I think it was difficult at that stage. Right. Sorry. Yeah. Oh.
Thank you so much, Dr. Fadi, for your informative presentation. I think the polypharmacy issue is, I think it's general everywhere, because we already, we have a master student here, he already did inappropriate medication in the patient with psychiatric problem here in Beirut, and we found the same problem. We have polypharmacy, we have inappropriate medication, or potentially inappropriate medication. Yeah. But at the end of the day, how can we prevent them? Because we know those geriatric patients, they already have so many medications, so many diseases. We need to prescribe so many medications. So the main question is, how can we prevent or minimize those inappropriate? One idea in the US where I did my study, they have this annual or seasonal pharmacist
medication
intervention,
review.
Or they call it pharmacist reviewing the charts and send recommendation to the physician. And the nursing homes in the US, they have required from the physician to respond to the pharmacist. Because also we did study here in Iraq that the response rate of the physician to the pharmacist recommendation is not more than 17%. While in the US, because it's required by law, it's like 100%. So this is one question. And also the other question is, we have multiple antipsychotic medications. One suggestion is, do you think using behavioral intervention is enough to reduce those antipsychotic? But as a result of that, if we need to reduce those number of antipsychotic, we need to have enough staff. They always understaffed. Like in my study in the nursing home, they always understaffed. So this is the second challenge. We have so many medications. How can we prevent them? Can we prevent them by pharmacist review only? Can we do this by the pharmacist intervention? And the third question is, what type of MARS did you use? Like, is it medication administration record? Is it electronic or is it
paper-based?
The paper is it's more susceptible to error because the nurses may not check the box.
They consider omission,
But in the electronic one, they say you must sign this or check it.
Confirm.
You go to the next page.
Exactly, confirm.
Like in the nursing homes, I did my study. They have two types of charts: electronics and the paper ones. The paper ones were more susceptible to errors because the nurse can leave the box without checking. But in the electronic one, it's must. You should check this. What do you think about that? Do you have any suggestion to reduce those polypharmacies or reduce administration error?
The main intervention, pharmacy medication review. There is a medication review every 6 months for care homes. This is like a regulation or policy. So I think one of the main thing is doing like medication review.
Okay.
I think this is the main thing. Maybe also the same reason, not much staff, so they just administer the medication. I think better to have like a specialist and doing like the behavior intervention for the use of the antipsychotic. One of the problems they notice in care homes, some of the staff, they just prescribe or not prescribe, administer antipsychotic to make the resident go to sleep. So this is also considered one of the issue. So I think behavioral or using other procedure, not just rely on the antipsychotic medication. I think this one. And also there's a new study, they explain that there's a type of training for clinician. This type of training when they attend, for example, course or workshop for several weeks, they end up with huge decrease in the prevalence of polypharmacy and potentially inappropriate medication. So training session, I think, is also important to overcome this issue. Hi.
Dr. Fadi, first of all, thank you for this very nice presentation. As you said from your study, using anticholinergic drugs for a long time for elderly may cause cognitive problems.
They notice.
So using antidiarrheal drug like atropine sulfate may cause dementia?
It depends on the score. So, for example, depend on the name of, for example, hyoscine and butylbromide, because I didn't put the scale or the score. Hyoscine, I'm not sure if it's score 1 or 2. So each medication, they have a score. For example, promethazine, score 3. So with the highest responsibility for causing anticholinergic or cognitive impairment. So depend on the medication. So they have anticholinergic properties, but there is like a table which classify them into 4 score. So we can know if it is score 1 or 2 or 3. Score 3 is the highest one. Then they notice the accumulative use of drug with anticholinergic properties. So, for example, as I mentioned, some of the medication, some of the residents may receive a score 9 because 5 medication, all of them or 3 of them with anticholinergic properties, and 3 of them within score 3. So it end up with score 9, which is related to dementia. Yeah, and especially for long-term use.
Most of them around 83 years.
Yeah. I think this is very important here also to consider drug with anticholinergic properties, but for long-term use. Yeah.
Because here they used it much.
Yeah, exactly.
Especially the
spasmopan, antidiarrhea. Yeah, but it's very important. Months, maybe months, irregular. Yeah, months. Yeah. But if not considered as a time, still it may have risk. So there should be used with caution, especially for older adults. I finish.